Good day. I will be presenting to you the topic nutrition. The topic is divided into two lectures, a part 1 and a part 2. The learning objectives for the lecture are: discuss lipid and water-soluble vitamins in both deficiency and excess states, discuss trace elements in deficiency and excess states, and thirdly, discuss protein energy malnutrition and obesity. Nutrients. Nutrients can be divided into categories of macro and micronutrients. Macronutrients define carbohydrates, lipids, protein, and major minerals. Micronutrients, on the other hand, consist of vitamins and trace elements, and it is this that will be the focus of our lecture. Most micronutrients function as cofactors for enzymes, or prosthetic groups for enzymes. Micronutrients can also be involved in various antioxidant reactions and can be protective for cell health. States of excess or deficiency both can harm human beings, and these must then be monitored to maintain optimal health. Micronutrients. I will first consider the fat-soluble vitamins A, D, E, and K, and then discuss the various water-soluble vitamins. I will then progress to discuss the trace elements. Vitamin A. The family of vitamin A consists of retinol, trans and cis formations of retinals, and carotenoids, for example, beta-carotene. The vitamin A compounds are transported in circulation bound to retinol binding protein produced by the liver, which then complexes thyroid binding prealbumin. The vitamin is able to signal intracellularly by complexing to retinoid X receptor and retinoic acid receptor, and then binds responsive elements in DNA to bring about biological change. The three key functions of vitamin A are in vision. They are components of the visual pigments. They also act as cofactors for the synthesis of mannose-containing glycoproteins. And thirdly, they are responsible for cell growth and differentiation, as well as mucin production. Vitamin A deficiency causes night blindness, keratomalacia, which describes a softening and ulceration of the cornea, the formation of Bitto spots, which are white, thickened epithelial areas in the conjunctiva. The ocular signs can also demonstrate infection and progress to blindness if untreated. Milder respiratory infections are also noted. Functional deficiency of vitamin A occurs as a result of malabsorption, as vitamin A requires mixed micelles within the GIT to be absorbed, as well as a decrease in retinol binding protein. Thus, vitamin A stores may be replete, but vitamin A deficiency signs and symptoms will present. Vitamin A can also exert toxic effects at excess states. It can cause raised intracranial pressure acutely. In addition, it can cause bone damage, fractures, and hypercalcemia more chronically. The retinol form of vitamin A is teratogenic and should be avoided during pregnancy. The carotenoids impart an orange skin coloration in excess states. Vitamin D. Vitamin D requires activation of precursors vitamin D3, cholecalciferol, and vitamin D2, ergocalciferol. The activation steps are affected in the liver and by the kidney. The 25-hydroxylase and the 1-alpha hydroxylase is able to activate both cholecalciferol and ergocalciferol. Vitamin D exerts ubiquitous functions as the receptor is present in a large variety of tissue. The 25-hydroxycholecalciferol form provides the current best measure of body stores. Vitamin D is responsible for bone health. However, a large number of studies have described its importance in non-skeletal actions. These include cancer, diabetes, and optimal immunology health. Deficiency states usually result in rickets and osteomalacia in children and adults respectively, poor bone mineralization, bone abnormalities, and increased fracture risk. In addition, dietary defective synthesis in, for example, chronic kidney disease, as well as defective actions of vitamin D, can result in deficiency states. The toxic states of vitamin D are usually evidenced at greater than 150 nanomoles per litre, and this can occur from excess supplementation of vitamin D. Vitamin E. Vitamin E consists of 10 related substances, each containing a 6-chrominol ring and a side chain. The side chains can vary. Alkanes or alkenes can give rise to tocopherols and tocotrienols respectively. Alpha-tocopherol is the dominant vitamin E moiety in circulation and constitutes about 90% of the total vitamin E metabolites. The major function of vitamin E is its antioxidant action. It also, at high vitamin E doses, is able to antagonize vitamin K, causing a bleeding diathesis. Doses of vitamin E therefore need to be carefully considered during supplementation. Vitamin E deficiency can occur in premature infants, malabsorption states, and A-beta lipoproteinemia. Beta lipoprotein is necessary for the transport of fat-soluble vitamins, for example vitamin A, from the enterocyte into the plasma. And in conditions of its absence, vitamin A then can be restricted to accessing systemic circulation. Deficiency presents with spinocerebellar ataxia, myopathy, hemolytic anemia, and pigment degeneration. Vitamin K. Vitamin K1 is termed phylloquinone, vitamin K2 menaquinone, and synthetic derivative of vitamin K2 is called vitamin K3, and this is used to commonly treat patients. Vitamin K employs carboxylation of glutamic acid residues on proteins. A special set of proteins called GLA proteins are important in coagulation reactions as well as in bone mineralization reactions. So in other words, the protein, the precursor protein, becomes active to the GLA protein only when it is carboxylated, and vitamin K is important for this reaction. This image highlights the functions of vitamin K. Reduced vitamin K is able to carboxylate GLA precursor proteins, resulting in active GLA proteins. Examples of GLA proteins are the coagulation proteins 2, 7, 9 and 10 and protein C and S. Also important is the various proteins responsible for bone mineralization. Example, osteocalcin, that's contained in osteoblastic cells. Vitamin K has to be in its reduced form to enable carboxylation of the glutamyl residues on the precursor GLA proteins. However, once it's effected this action, it forms an epoxide. It is important that the epoxide then be reduced by successive reactions, epoxide reductase, and the NADH quinone reductase. It is only the reductive form of vitamin K that can then be recycled to recarboxylate the GLA precursor proteins. The deficiency of vitamin K can result in a bleeding diathesis because clotting factors are not synthesized. Long-term deficiency is also thought to occur in osteoporosis and cardiovascular disease. However, evidence is not fully supportive and clinical guidelines do not recommend routine administration of vitamin K in these conditions. In the newborn, vitamin K prophylaxis against hemolytic disease is recommended. This is especially so in premature infants that have very low vitamin K levels. Malabsorption syndrome and liver disease may also result in a functional vitamin K deficiency, which may be resolved on administration of vitamin K and monitoring the response post-administration. Vitamin K toxicity has not been reported. Vitamin K can be monitored by surrogate markers, prothrombin time and INR, and these then provide a measure of the degree of carboxylation of the hematological factors responsible for coagulation. The serum phyloquinone levels may identify recent ingestion, and undercarboxylated vitamin K dependent proteins, for example PEVCA2, is preferred. Thiamine, B1. The active form of thiamine is thiamine pyrophosphate. It is especially important as a coenzyme in various enzyme reactions, decarboxylations, transketylation, and metabolism of branched-chain amino acids. B1 deficiency results in peripheral neuropathy, muscle weakness. This is termed dry beriberi. In contrast, wet beriberi presents with cardiac failure and edema. Another clinical manifestation of B1 deficiency is the Wernicke-Korsakoff syndrome. This results from severe deficiency of thiamine. Memory loss, abnormal eye movement, ataxia and stupor are presenting features, and these represent a medical emergency. It can develop into psychosis if it remains untreated, and then Wernicke-Korsakoff syndrome tends to be refractory to B1 supplementation. There are rare genetic abnormalities in thiamine that interrupt transport and metabolism of the vitamin and consequently also result in deficiency states. The B2 vitamin, riboflavin, defines the riboflavin mononucleotide, FMN, and the dinucleotide form, FAD. These provide prosthetic groups for oxidation reduction reactions in metabolic pathways. For example, cytochrome C reductase, succinyl-CoA dehydrogenase, and glutathione reductase. Deficiency usually occurs with other nutrient deficiencies and clinically presents with angular stomatitis, an inflamed red tongue, skin abnormalities, seborrheic dermatitis, and corneal vascularization and lens opacity. Niacin, vitamin B3. This consists of NAD and NADP. These are the biological cofactors of the vitamin, and they act as hydrogen acceptors in oxidative reactions and hydrogen donors in reductive reactions. Deficiency of B3 vitamin results in the clinical presentation of pellagra, characterized by dermatitis, diarrhea, and dementia, the 3Ds. Milder deficiency can result in glossitis and a burning, painful oral cavity. Deficiency can also be precipitated by disruption of a minor pathway involved in the production of niacin. This occurs via the metabolism of tryptophan, which is used to form the B3 vitamin. Drugs, for example isoniazid, or disease states like carcinoid syndrome or Hartnup disease, can disrupt the formation of nicotinamide and niacin via this pathway, and consequently patients then present with B3 deficiency. This occurs through the metabolism of tryptophan to an intermediate called kynurenine pathway, and this then requires both pyridoxine and riboflavin to metabolize and form B3 vitamin. So any drug or disease state that disrupts this intermediary minor tryptophan pathway to form niacin causes a niacin deficiency. Pantothenic acid is B5 vitamin and a component of the coenzyme A complex. It is available widely from the diet, and it's involved in many metabolic pathways, in particular the production of fatty acids. Deficiency states are poorly characterized and may present with apathy, numbness, and painful paresthesia. Vitamin B6, pyridoxine, can result in deficiency states, presenting with seborrheic dermatitis, fasciitis, angular stomatitis, conjunctivitis, somnolescence, neuropathy, and anemia. Isoniazid treatment can inactivate derivatives with pyridoxal phosphate. Penicillamine antagonizes B6. B6 therefore can be given as a prophylaxis in treatments that result in a deficiency state. For example, patients treated with antituberculous drugs, which include isoniazid, are prophylactically administered B6 vitamin. Alcoholics and infants on formula feeds may also present with deficiency. B6 dependent syndromes, example sideroblastic anemia, may also result in a deficiency. The B7 vitamin biotin is important as a coenzyme for carboxylase enzymes. It carries activated carbon dioxide and then performs single carbon transfers to substrates. It is covalently bound to enzymes at the lysine residue in the specific biotin-dependent enzymes. Carboxylases that require B7 are acetyl-CoA carboxylase, propionyl carboxylase, pyruvate carboxylase, and methylcrotonol carboxylase. For example, B7 is important in gluconeogenesis and lipid biosynthesis via pyruvate to oxaloacetate formation and acetyl-CoA to malonyl-CoA, respectively. B7 biotin. Clinical deficiency is rare but can present with dermatitis, alopecia, and conjunctivitis. Deficiency states can result from multiple carboxylase deficiency. This results from defective linkage of biotin to the carboxylases, alternatively, removal of biotin from the carboxylases during degradation. Biotin-related enzymes can also cause multiple carboxylase deficiency. The two enzymes implicated are biotinidase deficiency and holocarboxylase synthetase deficiency. These enzymes are responsible for resulting in the release and absorption of biotin from the GIT and the attachment of biotin to the carboxylase, respectively. The consumption of raw egg can also produce deficiency of B7 because the avidin in the raw egg is not inactivated by cooking, and this glycoprotein decreases biotin absorption from the GIT system. The pregnancy state can also produce deficiency and potentially can be dangerous for the developing fetus. Folic acid B9. This is an important vitamin for 1-carbon transfer reactions and methionine metabolism. THF and 10-formyl THF are the principal derivatives and contain a different number of glutamic acid residues. They are enzyme steps involved in the formation. DHF reductase and MTHF reductase are important in the formation of tetrahydrofolate and 5-methyl tetrahydrofolate. Single carbon donor reactions and single carbon acceptor reactions result in the production of products in different 1-carbon transfer reactions. Folic acid B9 deficiency is best characterized in megaloblastic anemia. This anemia results because DNA synthesis is disrupted and thymidine monophosphate coupled with purines are not synthesized. The red blood cells appear enlarged and the anemia requires B9 supplementation. Dietary insufficiency of B9 also causes deficiency. Increased utilization states, increased loss can also result in vitamin B9 deficiency. The use of drugs, for example, pyrimethamine, act as folate antagonists, and these also cause deficiency states. Ethanol and phenytoin are important in resulting in impaired absorption of B9 from the GIT system. Increased excretion is also caused by ethanol. Vitamin B9 can be quantified by red blood cell folate measurement and plasma levels. Red blood cells are superior as they are not influenced by recent ingestion of folate. The plasma levels also may tend to increase in B12 deficiency due to reduced conversion of the methyl tetrahydrate, a hydrofolate form, to THF. Red blood cell folate concentration, however, also decreases in B12 deficiency. Genetic variation in methyl tetrahydrofolate reductase is common, and this may also affect red blood cell folate measurement. It's therefore important to note potential factors that can impinge on low folate red blood cell levels to avoid spurious diagnosis. Vitamin B12 is synthesized by microorganisms and has quite a unique structure as a vitamin. It also contains cobalt, which is important for its function. It functions predominantly as a coenzyme involved in reactions that include methylmalonyl-CoA to succinyl-CoA and homocysteine conversion to methionine. Vitamin B12. Vitamin B12 has a complex absorption. HCl releases B12 from protein ingestion, and the B12 then complexes haptocorin, also called transcobalamin 1. Within the duodenum, this is cleaved and is able to bind intrinsic factor. At the ileum, it then is internalized, and the B12 and the intrinsic factor separate. The B12 then complexes to transcobalamin 2, which is also called hollow transcobalamin or active B12. Other complexes with transcobalamin 1 and transcobalamin 3 do not release B12 as easily to the tissues. Hence, transcobalamin 2 is very important at a functional level. The deficiency states can result from dietary low amounts of HCl being produced in the stomach, bacterial overgrowth, fish tapeworm, which binds to cobalamin, pernicious anemia, which results in binding and blocking antibodies, and ileal disease. B12, like folate, also presents with megaloblastic anemia. In addition, subacute degeneration of the spinal cord can result, and long-term deficiency can cause psychosis and dementia. The assessment of B12 can be conducted by immunoassay. It can also be decreased with folate deficiency. Methyl malonate and homocysteine are elevated. Pernicious anemia etiology can result in the production of intrinsic factor antibodies in approximately 90% of patients. However, 15% of the healthy population are also intrinsic factor antibody positive. What is the relationship between folate and B12? Dihydrofolate reductase enables the formation of tetrahydrofolate. B12 is an essential cofactor for this reaction. THF polyglutamates then are formed, and this enables the conversion of deoxyuridine monophosphate to deoxythymidine monophosphate, and this product then is important for DNA synthesis. Hence, if either or both B12 and folate are deficient, megaloblastic anemia may result due to poor formation of DNA and abnormal red blood cell development. Vitamin C is a water-soluble vitamin, also known as ascorbic acid. Its biologically active forms are interconvertible L-ascorbic acid and aldehydrascorbic acid. It functions as an electron donor in several enzyme reactions that are responsible for collagen synthesis, carnosine synthesis, and the synthesis of monoamine neurotransmitters. Vitamin C is important as an antioxidant. It scavenges free radicals and facilitates the absorption of non-heme in the ferrous 2+ reduced form. The vitamin C antioxidant scavenging is indicated in the image. You can appreciate that ascorbic acid is regenerated to cycle through repeated protective cycles of mopping up oxidative species. Vitamin C deficiency can take approximately 2 to 3 months to develop and result from not ingesting food that contains vitamin C. Scurvy is the classical, well-documented presentation of vitamin C deficiency and presents with a variety of symptoms: wound healing, hemorrhages, abnormal behavioral changes, decreased iron absorption resulting in anemia. In addition, subclinical deficiency may require laboratory confirmation. High-dose treatment is unproven in risk reduction of disease, and administering vitamin C to patients routinely is not advised as a primary prophylaxis. Vitamin C toxicity can result in diarrhea and indigestion, renal stones, although data is not fully convincing, and intestinal saturation usually occurs at 1 to 2 grams per day. As this vitamin is water-soluble, it is excreted by the kidney when the saturation point is reached. We'll now consider the second class of micronutrients, trace elements. Copper. Copper is involved in various reactions. I've provided a list of enzymes and the main products of their synthesis in this slide. Copper deficiency is rare. Parenteral nutrition, malnutrition, and malabsorption can precipitate deficiency. High zinc intake is also responsible for vitamin deficiency as it decreases copper absorption. Vitamin C reduces copper absorption as it converts copper to its less soluble Cu plus form. Copper is excreted via a biliary route and accumulates in the liver during cholestasis. Deficiency presents with microcytic anemia, neutropenia, and osteopenia. Quantifying copper using serum assays can identify deficiency. Copper levels are decreased, as is ceruloplasmin, its carrier protein. Positive acute phase responses confound interpretation of the measured copper. Ceruloplasmin increases, thus increasing the total concentration of copper, as 90% of copper is bound to this binding protein and in circulation. Acute phase reactants and oral contraceptives can increase ceruloplasmin, and the diagnosis of marginal deficiency can be missed. The enzyme activity ceruloplasmin assays may assist in the diagnosis as it exploits the detection of apoceruloplasmin, which increases in copper deficiency states and decreases the enzyme activity. Superoxide dismutase, the SOD enzyme contained in red blood cells, can also indicate copper tissue stores. Conditions that increase copper can result from inherited diseases, for example, Wilson's disease and Menkes disease. There is reduced incorporation of copper into its binding protein with high copper excretion and tissue deposition. Iodine is important for the production of thyroid hormone. Dietary iodine is reduced to iodide in the gut. Dietary deficiency may result from goitrogens and endemic goiter. Toxicity, however, is uncommon. The urinary iodide excretion reflects dietary intake. Chromium. Chromium's mechanism of action is incompletely elucidated, and chromiumodulin is thought to be important for its role in insulin signaling. Chromium deficiency impairs glucose tolerance. However, its role in diabetes is not completely understood. Lipoprotein metabolism is also affected, and supplementation with chromium reduces triglycerides and cholesterol levels. Chromium deficiency is also noted in parenteral nutrition. In contrast, toxicity states may result during use of prosthetic joints and excessive dietary intake. Selenium. Selenium is important for enzyme functions, in particular glutathione reductase, thyroid hormone T4 to T3 conversion, and thyrodoxine reductase. Dietary deficiency, for example, in Keshan's disease, results in myopathies. Long-term peripheral nutrition, coupled with inborn errors of metabolism, can also cause deficiency. Plasma levels reflect recent selenium intake, and glutathione peroxidase, alternatively selenoprotein P, provide better measurements of selenium status. Zinc. Zinc is a cofactor for many enzymes. The zinc finger proteins enable small ligands to bind larger molecules, for example, DNA. Animal sources are a ready source of zinc, and phytates in cereal bind zinc and limit its bioavailability. Metallothionein protein is upregulated when zinc intake is very high, and consequently, This can reduce copper absorption. Zinc's wide distribution, in particular muscle and red blood cell, causes deficiency to be uncommon. Zinc deficiency usually results from an increased loss, alternatively inadequate parenteral nutrition. Zinc excess causes similar features to copper deficiency: dermatitis, hair loss, immune impairment, wound healing, diarrhea, and impaired growth have been identified. In addition, acrodermatitis enteropathica is an autosomal recessive disorder causing a decrease in zinc absorption and results in states of zinc deficiency. Manganese. Manganese is present in various enzymes listed. Deficiency states are rare, presenting with weight loss, dermatitis, reduced cholesterol, and triglycerides. Toxicity results in cholestasis and movement disorders and can occur in children on parenteral nutrition as well as in minors due to workplace exposure. And finally, molybdenum. It's a cofactor for 4 enzymes that I've listed. Deficiency is also rare, with long-term parenteral nutrition being a cause. Molybdenum is a cofactor and its deficiency is very rare. Low toxicity, supplements and worker exposure has been reported in toxic states. I will now be discussing the final learning objective, protein energy malnutrition and obesity. We'll start with protein energy malnutrition and talk to the definition of protein energy malnutrition and the different types of clinical syndromes that it can present with, and more specifically the laboratory's role in managing this group of patients. Poor protein intake. Poor protein intake can manifest in clinical syndromes. The 3 most common syndromes are marasmus, Kwashiorkor, and marasmic Kwashiorkor. The last syndrome is a combination of the former 2. Marasmus. Marasmus results from chronic starvation, and this then results in generalized wasting. It is caused by having both energy and protein deficiency. It is common in developing countries where access to a balanced energy and protein diet may be restricted. Kwashiorkor, on the other hand, is characterized by edema. This clinical feature can be unilateral or symmetrical and is a result of low protein intake. It usually occurs in children population and it occurs after weaning. So when children move on to diets that are unbalanced with low protein, for example, a predominance of corn-based nutrition. Kwashiorkor is usually accompanied by extreme infection, and this makes the children further unwell. The clinical parameters of classifying undernutrition include weight for height Z-score, mid-upper arm circumference, and classifying patients into acute and chronic undernutrition by identifying standard deviations. -2 to -3 SDs classify moderate, or less than 3 SDs severe acute undernutrition. Chronic undernutrition can be identified by malnutrition without edema and weight or length for age Z-scores of less than -2. Thus, in summary, undernutrition and edema will define a Kwashiorkor category, and moderate or severe undernutrition without edema defines marasmus. The image on the right demonstrates a patient with Kwashiorkor with extreme bilateral edema coupled with severe skin changes, possibly brought about by infection of the skin. Looking at the anthropometric classifications, marasmus and Kwashiorkor are listed here. There are different types of classifications, and the WHO system of definitions can be used. Marasmus then is malnutrition without edema, but a weight for height or length Z-score of less than -3 or a mid-upper arm circumference of less than 11.5. Kwashiorkor will be defined by a weight for height Z-score of less than -2 or a mid-upper arm circumference of less than 12.5, which will define wasting. Alternatively, you can also have a stunting category. This slide illustrates the moderate and severe malnutrition categories that are advocated by WHO. You will appreciate the key features of edema being present or absent. It is absent in the moderate category, present in the severe category. You will also identify the weight for height Z-score, or the MUAC, the mid-upper arm circumference being utilized to define moderate wasting or severe wasting. Also, the height for age Z-score assists in defining and differentiating moderate from severe stunting. The presence of symmetrical edema does define Kwashiorkor, and this occurs regardless of other anthropometric parameters. There is also a definition of the Z-score that is utilized in this classification system. We'll now talk to Kwashiorkor. These slides, the next 2 slides or so, are derived from the BMJ best practice from 2022 to reiterate Kwashiorkor, or edematous malnutrition, is characterized by bilateral pitting edema. There's no other cause for the edema, so that has been excluded, and it's accompanied by dermatoses, anorexia, and an apathetic child, usually. Etiology remains ill-defined and is thought to be linked to the dietary protein deficiency that we've spoken to. It is typically associated with a corn-based diet, recent weaning, measles, or diarrheal diseases. It commonly occurs within the sub-Saharan African area, associated with other chronic diseases like tuberculosis or HIV, and these tend to have high prevalences, these latter diseases, within the sub-Saharan area. It can also occur where the children are restricted with adequate nutrition. In uncomplicated cases, the child can be managed as an outpatient with ready-to-use therapeutic food. However, inpatient admission is required for very ill patients, where their nutritional needs then can be better catered to. The complications of Kwashiorkor include infections, for example TB and HIV, hypoglycemia, hypothermia, xerophthalmia, electrolyte disturbances, and cardiac failure. The laboratory aspects of the workup of Kwashiorkor are generally unnecessary, as Kwashiorkor is a clinical diagnosis. HIV, TB, and other coexisting conditions need to be identified to ensure that adequate treatment is administered. In addition, other differentials of the edema need to be excluded, and the laboratory can contribute to this. Also, other complications can be assessed. The hemoglobin level and the pack cell volume can identify anemia. Hypoglycemia may be present at less than 3 millimoles per litre. The electrolyte profile can be abnormal, variably so, in this group of patients. The Refeeding Syndrome may also be observed on commencement of nutrition support. Serum albumin and protein levels are usually normal or low. However, if they are extremely low, then an alternative diagnosis for the edema may be considered. Hypophosphatemia, hyponatremia, hypokalemia have been observed in these patients, and these would need to be appropriately supported. Infective screens, blood, stool, urine, malaria, HIV, and TB need to be considered in these patients as they are especially prone to infection. Urine dipstick analysis for proteinuria and hematuria may be helpful as methods to exclude other causes of edema. Also, echocardiography may be performed to exclude other causes of edema if there is some form of diagnostic uncertainty. Small pericardial effusions have been reported in some cases of Kwashiorkor. Obesity. Obesity is a world health problem and is common. Its prevalence is increasing both in pediatric populations and adult populations. This occurs in developed and developing countries. The BMI forms quite an essential part of defining obesity, with cutoff points greater than 30 in adults and greater than 95th percentile in pediatrics, usually defining the category obesity. Waist circumference marker is also used to assist in identifying abdominal fat stores. The long-term health risk of obesity is well defined in the literature and includes many diseases, for example, cardiovascular disease, type 2 diabetes mellitus, cancer, and many. The pathogenesis of obesity is multifactorial. It is essentially a consequence of an imbalance between the amount of energy consumed and the amount of energy expended. The complexity of obesity is underlined by various contributory mechanisms, and these include psychosocial, drug-induced, infection, various types of endocrinopathies, neurological, as well as monogenic disorders. Appetite control is key to obesity. Appetite control is regulated by complex neuroendocrine mechanisms. These inputs into appetite are multifactorial neurological control centers in the brain, coupled to endocrine signals, both from the gastrointestinal tract and the pancreas, provide a complicated neuroendocrine mechanism for controlling appetite. There are various central hypothalamic nuclei that are involved in the regulation of food intake. These include the arcuate, paraventricular, lateral hypothalamic, ventromedian, and the dorsomedian nuclei. Signals to the brain that control appetite are provided by both peripheral signals as well as gastrointestinal hormones. These then interact with the various hypothalamic nuclei to regulate peptides that control appetite by suppressing or increasing appetite. The factors that stimulate appetite are termed orexigenic peptides and these include neuropeptide YY and agouti-related peptide. In contrast, anorectic peptides or factors suppress appetite, and the two prototypes are CART and POMC, cocaine and amphetamine regulated transcript, and pro-opiomelanocortin. The latter, POMC, also undergoes post-translational modification to form alpha-melanocyte stimulating hormone that acts and signals centrally to cause the appetite suppressive effects. Serotonin also has the ability to act on POMC neurons and cause depression of appetite. It's thus evident that the interaction is quite complicated at the central level. There are various hypothalamic nuclei that are involved in the regulation of appetite. So if you consider the PVN, VHN, and the LHA nuclei, they are involved in various important suppressive or stimulating effects. PVN peptides cause a net catabolic effect with peripheral stimulation, sympathetic stimulation to peripheral tissues, which increases beta oxidation and lipolytic effects. VHN, this receives afferent signals and controls satiety and glucose homeostasis. LHA is important for orexigenic peptides. Other hypothalamic factors include the endocannabinoids, which are orexigenic, and nesfatin 1, which exerts an anorectic effect. Other areas of the brain are also involved in appetite control, and this includes the brainstem. The GIT, via the vagus nerve, is able to relay to the nucleus of tractus solitarius in the brainstem. Communication between the paraventricular nucleus and NTS also exists. The midbrain. The midbrain is considered to be involved in hedonistic feeding, and dopamine is released from midbrain neurons, which activates then other pathways involved in appetite control. Peripheral signals regulate food intake. Leptin is produced by adipocytes. It signals via arcuate receptors in the hypothalamus, increasing the anorectic to orexigenic peptide ratio, and in so doing, decreasing food intake and energy expenditure. Leptin is also produced in the stomach, and this results in satiety signals. In addition, peripheral signals are also generated postprandially by the pancreas. The release of insulin signaling to the arcuate nucleus decreases food intake. The third arm of appetite control is via the gastrointestinal hormones. Insulin has anorectic effects on the brain. In addition, during the fasting state, the stomach produces ghrelin, and ghrelin increases food uptake. Satiety is also influenced by a varied number of hormones that I've listed: peptide YY, pancreatic polypeptide, cholecystokinin, glucagon peptide 1, abbreviated GLP-1. We'll come across the last hormone again in the pharmacotherapeutic interventions. In addition, nutrients themselves are able to increase satiety. Long-chain fatty acids, LCFAs, coupled with amino acids, are able to induce satiety. Managing the obese patient. Some considerations that one may make in managing this group of patients is to screen for chronic disease associated with obesity. In addition, medications that contribute to obesity can be identified, as can contributory factors to patients becoming obese. The screening for secondary causes of obesity can be guided by the clinical presentation. In addition, as obesity increases cancer risk, cancer screening guidelines can be used to screen for cancers in this group of patients. The principles of managing obese patients are threefold: dietary and lifestyle, pharmacotherapeutic interventions, and bariatric surgery. Dietary and lifestyle is fundamental to successful management of obesity and is the first line of intervention. Diet and calorie restriction, however, can cause loss of muscle. This can be counteracted by appropriate exercise. Also importantly, exercise predicts sustained weight loss more than diet alone. So the combination approach of dietary caloric restriction with exercise is recommended. Weight loss programs also potentially exert positive psychosocial support to prevent weight regain. Pharmacotherapeutic interventions are indicated for BMIs at greater than 30, alternatively BMIs of 27 and more with comorbidity. Bariatric surgery is indicated for BMIs greater than 40 or BMIs greater than 35 with comorbidity. Pharmacotherapeutic options are varied with different types of drugs on the market and approved for anti-obesity. The mechanisms of the drugs are variable. I've listed some of these drugs on this slide, and we will take a closer look at other drugs in the following slides. Pharmacotherapy can be administered in the short term, and usually sympathomimetic amine drugs are recommended. For example, phentermine. These do have side effects, and the adverse effect profiles need to be considered when administering these drugs. Other long-term anti-obesity medication include drugs like orlistat, which is quite commonly available and commonly used. This is a gastric and pancreatic lipase inhibitor. In contrast, other drugs can act centrally to exert anti-food intake behavior. Other long-term pharmacotherapeutic interventions include GLP-1 analogues and sympathomimetics. For more detailed reading of the different drugs and their actions, I've listed the reference by Kim et al. Bariatric surgery. Bariatric surgery is safe and it's also effective for the high-risk group of patients, and it has shown long-term success in the severe obesity group. It is important that clinical decision-making be evidence-based when approaching these patients, also considering their various chronic disease profiles. A team approach is advised to perioperative care, and it is mandatory with special attention to nutritional and metabolic complications and general care of the patient. This systematic review identified that the weight loss was certainly durable and effective by various bariatric procedures. The pink highlights indicate the various mean weight loss amongst the different procedures. These varied between 45 to 74%. So substantial and durable weight loss is certainly evident in bariatric surgical procedures. It's also important to note that reoperations do remain likely in this group of intervention, this group of surgical intervention. Bariatric surgical procedures are listed here. The restrictive procedures include vertical banded gastroplasty, VBG, as well as laparoscopic interventions, laparoscopic adjusted gastric banding. In contrast, the combined restrictive and malabsorptive procedures include the Roux-en-Y gastric bypass, biliopancreatic diversion, with or without a duodenal switch. The question that we ask is, how effective is bariatric surgery? Bariatric surgery reduces complications and mortality associated with obesity, and the metabolic abnormalities of the patient pre-surgery resolve during the post-surgical period. And it's hypothesized that the surgical procedures bypass the proximal upper GIT and cause these metabolic abnormalities to improve, or the quicker rate of delivery of the food contents to the distal GIT increases the enteral hormone secretion. In addition, other contributory factors of altered bile acids, the various inputs of hormones from adipose tissue, as well as gut flora, are implicated in improving the overall metabolic profile that makes it more favorable. GIT hormone profiles are altered during the post-surgical period. Satiety hormones have been shown to increase, GLP-1, PYY, and the orexigenic peptides decrease. So the net effect then of bariatric surgery is effectively decreased appetite and improved weight loss. The complications of bariatric surgery include 0.2% mortality. This mortality rate, however, is improved in comparison to the severely obese patients who have high mortalities and morbidities without surgery. Bariatric surgery also complicates acutely and later as well, and this points to the need for biochemical monitoring both in the acute post-operative state as well as later. The acute complications include anastomotic leaks and post-operative bleeding, whereas the late complications include nausea, bowel obstruction, fistulae, strictures, nutritional deficiencies, and the dumping syndrome. The biochemical monitoring of bariatric surgery patients are provided for by clinical guidelines. I've listed 2 resources in this slide that expand and provide detailed information on this topic. We will very briefly identify some lists that are derived from these guidelines. Monitoring of patients that have undergone laparoscopic gastric banding, standard blood tests, FBCs, biochemistry, biomarkers of hypoglycemia, lipid profiles, as well as longer-term bone mineral metabolism parameters like DEXs, urinary calcium, as well as 25-hydroxy-D are recommended. In contrast, patients who've undergone laparoscopic sleeve gastrectomy can have tests that we've listed in the blue font, so those are the tests we've spoken about, but in addition, the B12 levels can be monitored, the thiamine levels can be monitored as well, and the routine monitoring of other vitamins is not usually required. Monitoring of patients who've had the other surgical interventions would require the standardized biochemical tests as for LSG that we've looked at in the previous slide, but also one would need to consider the fat-soluble vitamins K, E, A, and monitor for those as well, and this is where the lab can be of special help. In addition, copper and zinc can be annually monitored, and selenium can be monitored as well in particular subsets of patients. We've come to the conclusion of the first lecture. It is evident that vitamins and trace elements are critical for optimal health in humans. Deficiency and excess states of vitamins and trace elements do require correction to maintain this optimal health. Macronutrient deficiency can result in protein energy malnutrition. This can especially affect children in developing countries and cause high morbidity and mortality. Obesity. Obesity is a public health problem with a multifactorial etiology. However, it is amenable to dietary and lifestyle treatment, pharmacotherapeutic intervention, and bariatric surgical approaches. The biochemical diagnostic laboratory is important at various points in optimal screening, monitoring, and ongoing care of patients to optimize their nutritional health. Good day. We'll now be progressing on to part 2 of the nutrition lecture. The learning objectives for the second part include being able to ably advise on and participate in biochemical assessment of nutritional disorders, and ably advise on and participate in appropriate clinical and laboratory monitoring of patients that receive nutritional support. There are various techniques that are used to assess nutritional status. I've listed 7 techniques in this slide, and we will approach these, discussing some in more detail and alluding to others. Nutritional screening can form an important component of the nutritional assessment by providing identification of patients at risk of malnutrition. An example of a nutritional screening tool is MUST, Malnutrition Universal Screening Tool. It is easy to use, reliable, and valid. The tool utilizes 3 scoring criteria: BMI, weight loss, and disease effect. Patients then are stratified, and those at risk of malnutrition are referred for formal nutritional assessment. Dietary assessments. Dietetic methods can obtain dietary intake, conduct more formal dietetic assessments, identify quantitative and qualitative data about consumption of food. The Food Frequency Questionnaire can evaluate the consumption of different food groups that reflect a longer period of dietary consumption. The dietetic methods bring into question reliability and accuracy. Clinical assessment. Clinical history, increased nutritional need, nutrient losses, and decreased absorption can be obtained from patients. Clinical assessment can identify signs of general nutritional depletion and nutritional deficiencies. Subjective global assessment. This utilizes the patient history, clinical assessment to assess nutritional assessment to produce a subjective global assessment rating. The rating can classify patients into a well-nourished, a moderately malnourished, and a severely malnourished category. It then is able to predict the risk of complications associated with undernutrition accurately. Anthropometric measurements can be used to assess patients who are obese. Waist circumference can be used to prognosticate type 2 diabetes and assess obesity in fat stores. The waist-hip ratio contributes little more information. Fat can be assessed by measuring skin fold thickness. The tricep skin folds are most commonly measured and is abbreviated TSF. Mid-arm circumference can be measured as well to assess fat, muscle, and protein stores. This parameter is easily accessible, however, responds slower to changes in mass and is prone to measurement error. The arm muscle area can be calculated by utilizing the MAC and TSF variables. There are problems with utilizing anthropometric measurements. These include weighing patients. However, normograms can be useful to predict height. Intra and inter-observer variation may compromise accuracy of anthropometric measurements. The measurements are also not ideal for short-term assessment, as patients need to demonstrate a large loss of many kilograms in order to identify a quantifiable change. The BMI is a commonly utilized metric to assess patients' status of obesity. The BMI is calculated using variables mass and height. Its units are kgs per meter squared. Various cutoff points categorize patients into underweight, normal, overweight, obese, and severely obese categories. The BMI does suffer from some problems. It measures body mass, or rather utilizes body mass in its calculation, and ignores states of confounding hydration and edema. It's sometimes also difficult to measure height in pediatric populations. The fat distribution is not able to distinguish central versus visceral fat. Also, the cutoff points do not routinely utilize sex classifiers, age classifiers, and ethnic classification. There are some cutoff points that are able to distinguish Asian versus Caucasian patients' BMIs, and this can be useful. Athletes also may have larger muscle mass and consequently higher BMIs, but may not be obese. Age-specific centiles should be used to interpret BMIs in pediatric populations, as the proportions of body fat vary with age of the pediatric patient. Protein stores may also be assessed using functional studies of the muscle. Hand grip strength, respiratory muscle strength, and muscle function using electrical stimulation may be used to assess the function of muscle. The tools discussed thus far identify simple tools for nutritional screening, which enables referral of at-risk patients for formal nutritional assessments. The more complex methods of direct questioning, clinical examination, and clinical measurements can also be utilized. The effective use of all tools requires knowledge and skill. Monitoring changes over time may provide more useful measurements and information than merely conducting basal measurements. Are biochemical parameters, for example plasma proteins, useful in assessment of nutrition? This table identifies common plasma proteins that have been measured during nutrition assessment. The half-life of the proteins is variable and can identify acute and chronic changes. Also important is the variation in the plasma proteins as a function of various disease states, for example, positive and negative acute phase reactions. This can then potentially confound measurement. It is important that plasma proteins identify the entire body pool. The rate of synthesis of the plasma protein is rapid. The rate of its catabolism should be constant, and changes then should affect the entire body pool and be responsive to protein and energy restriction. The combination of plasma proteins with inflammatory markers, for example C-reactive protein, has been attempted to provide more accurate measurements. For example, the Prognostic Inflammatory and Nutritional Index can be calculated by utilizing acid glycoprotein, C-reactive protein, albumin, and pre-albumin measurements. And in critically ill patients, a score of greater than 30 correlates with the risk of mortality, and it thus can be important in screening patients that are very ill. So in summary, the laboratory's role in biochemical marker quantification in nutritional assessment identifies that there's no single laboratory measurement that can be used in isolation to assess nutrition status. Also, there are various limitations of all protein nutritional biomarkers. The clinical utility of biochemical biomarkers is especially strong in identifying specific nutritional deficiency states and not more broadly in nutritional assessment. The laboratory assessment of energy requirements. Laboratory-based testing can be used to measure energy expenditure and thus assist clinicians in the provision of nutritional support. Energy expenditure and energy requirements, however, are not synonymous. Laboratory-based testing is not in common use, however, to assess energy stores. Calorimetric laboratory measurements identify heat production by the body, and this can be done directly, although this is a more cumbersome approach, more expensive, and requiring specialized equipment and training of staff. Alternatively, it can be done indirectly, where the consumption of oxygen and the production of carbon dioxide can be quantified. Indirect measurements utilize open and closed circuit devices and thus enable the amount of oxygen consumed and carbon dioxide excreted to be measured, and then the resting energy expenditure and the respiratory quotient can be calculated from these measurements. This calculation can be used to calculate resting energy expenditure where VO2 and VCO2 are measured. Energy production. Energy expenditure at steady state reveals that energy released from foods is proportional to the amount of oxygen consumed. The amount of energy released by the consumption of oxygen is dependent on the individual food sources, and an average of 4.82 kilocalories per litre of oxygen can be utilised to calculate energy production. Energy expenditure can also be identified and predicted using equations, as we've discussed. Respiratory quotient can be calculated from calorimetric measurements of CO2 and oxygen and identifies this as a ratio. Oxidation of glucose produces an RQ of 1, oxidation of protein 0.8, and fat 0.7. Cutoff points of 0.85 and 1 then identify undernutrition and nutritional excess states. Basal metabolic rate can be calculated using variables age, sex, height, and weight of the patient. Examples of equations that calculate BMR include Harris-Benedict and Schofield. The severity of a patient's illness is likely to affect the calculation and thus may skew values. Body composition may be assessed using two or multi-compartment models. The two-compartment models are able to distinguish fat-free mass and body fat. Techniques used are bioimpedance, densitometry, and isotope dilution. Body composition can be assessed by multi-compartment models. These include computerized tomography, magnetic resonance imaging, and DEXA scans. In summary, nutritional assessment is essential to identify patients in need requiring of nutritional support. The use of a subjective global assessment coupled to objective nutritional measurements, can assist in the provision of a reliable assessment of patients in need of nutritional support. The use of more sophisticated and technically demanding methodologies are not routinely utilized in clinical medicine. Nutritional support. Some important definitions and distinctions are between malnutrition, overnutrition, and undernutrition. Malnutrition describes disorders in nutrition, and these constitute deficiency, impaired metabolism of nutrients, as well as overnutrition. It is thus important that we do not define malnutrition as being exclusively a problem of undernutrition. The patient's nutritional requirements need to reflect an energy target. 25 to 35 kilocalories per 24 hours is a general energy requirement of adults. However, tailoring the nutritional requirement needs to individual patients is required to ensure that their disease and general clinical condition is adequately met by way of providing them with sufficient amount of nutrition. This can be accomplished by the use of calorimetry and prediction equations that we've spoken about previously. The Schofield and Harris-Benedict equation can provide essentially a prediction of an estimate of energy requirement, and this can then be adjusted based on the patient's need. For example, trauma and sepsis patients and pediatric patients will need more energy requirement. The protein requirement also needs to be appropriately adjusted based on patient population, with a requirement of 0.8 grams per kg per 24 hours, reflecting an average adult consumption in health. This will clearly need to be increased by as much as twofold in different types of diseases, for example, significant trauma or significant sepsis. Nutritional support can be considered for patients who are malnourished or are at risk for malnutrition. Criteria that can be used to identify these patient groups include BMI and unintentional weight loss. Cut-off points can define, as illustrated in this slide, patients that are malnourished and consequently will require support. At-risk criteria include nutrient losses that are high, absorptive capacities that are reduced from disease, for example, nutritional needs that are especially high. Catabolism may be increased in patients that are significantly septic, no eating or eating very little in the last 5 days, and or likely not to eat or eat very little in the next 5 days, certainly will also identify at-risk patient groups. All of these patients then would need to be monitored, and the introduction of nutritional support would need to be decided on. Nutritional supplementation can be considered in patients at risk of malnutrition or patients that have malnutrition. Importantly, however, before commencing nutritional supplementation, it is important to ensure that other patient-related factors are addressed. For example, patients may not be able to mobilize, may have cognitive impairments, may have GIT-related problems, for example, diarrhea, vomiting, constipation. These sorts of factors and clinical conditions need to be resolved optimally before providing nutritional supplementation. The energy intake can be increased in patients that require nutritional supplementation by the introduction of normal diets. In the vast majority of patients, this should meet the necessary requirements. However, should a patient qualify for nutrition supplementation, modular supplements containing just single macronutrients can be added to their diet to supplement and fortify their needs. Nutritionally complete supplements can also be utilized. It therefore is important to tailor nutritional supplementation to the patient's clinical needs and context and address related clinical barriers that prevent adequate nutrition intake. For those patients who are inadequately supported by oral feeding, enteral nutrition can help to supplement their needs. This is especially important as approximately 40% of hospitalized patients have undernutrition, and sometimes then oral supplementation may be inadequate. Indications for enteral nutrition include malnutrition, swallowing difficulties, inability to eat, obstruction to the gastrointestinal tract, nutritionally high requiring patients, and anorexia. The routes of enteral nutrition are variable and depend on long and short term support. So the key aim then is introducing nutrients directly into the GIT system. Nasogastric tubes, for example, can be used in the short term, and the PEG approach, percutaneous, they can be used for long-term support. The composition of enteral feeds should be tailored to the patient's needs. In general, intact protein, glucose polymers, maltodextrin, and long-chain triacylglycerols are important components of enteral feeds. However, disease-specific feeds can be introduced or be used as complements to cater better to the patient's needs. For example, the introduction of fiber to improve constipation, increasing total amount of energy for patients who are high energy requiring, and restricting fluid within the enteral feed for patients that need fluid restriction. In patients who have renal failure, reduced potassium sodium phosphate and increased water-soluble vitamins can be considered. Immune modulating feeds are also available and can support patients, some groups of patients, better. One can also consider elemental feeds that are easier for patients to absorb, and this can be based on their clinical presentation. The complications of enteral feeding can include insertion-related complications, for example, nasal damage, bronchial placement, perforation, blockage of tubes. Gastrointestinal complications include reflux and intolerance. Esophagitis, aspiration pneumonia can occur due to refluxed content. Patients can also present with diarrhea, which is quite common, nausea and vomiting. The metabolic complications include refeeding, hyperglycemia, electrolyte and fluid imbalances. In general, the biochemical complications are less common in enteral feeding compared to parenteral nutrition. Parenteral nutrition requires a multidisciplinary delivery team, clinician, chemical pathologist or clinical biochemist, dietitian, pharmacist, specialist nurse, and total parenteral nutrition support can be used via an intravenous route to provide total nutritional needs. Sometimes total parenteral nutrition may not be needed, and patients can receive partial nutrition via the parenteral route, coupled with other forms of nutritional support. The composition of parenteral nutrition formulations are different, and as for enteral, need to be guided by the patient's nutritional needs and disease status. The indications for parenteral nutrition include GIT disease that precludes efficient GIT absorption of gut nutrients, also intestinal obstruction, paralytic ileus, short bowel syndrome, fistulae, dysmotility, and inflammatory bowel disease may curb the efficiency of enteral nutrition and thus support parenteral nutrition. Routes of administration. Parenteral nutrition can be administered via catheters that are placed into veins. The veins may be peripheral or central. Peripheral veins allow for quick access and avoids delays. However, it can be challenging to introduce nutritionally appropriate support peripherally. Patients may also develop phlebitis with high osmolar solutions or high volume solutions. Central venous catheters can be used for short and long-term administration of nutrition, and the catheter tip is placed in the jugular vein or superior vena cava. Peripherally inserted central catheters or non-tunnel central venous catheters can be used for short-term access. Tunneling of central venous catheters or the use of implantable devices can be used for long-term feeding. The complications of catheterization are different between peripheral and central administration. Phlebitis, infection, and venous puncture and thrombosis can occur peripherally. In addition to infection and thrombosis, the central venous catheters also are potentially at complication risk for air embolism, arterial puncture, pneumothorax, and mechanical problems of occlusion, displacement, and fracture. As for enteral nutrition, the composition of the parenteral formulation needs to consider the patient, and formulations can be supplemented accordingly. Carbohydrate, nitrogen, and lipid sources need to adequately provide for the energy requirements of the patient. Parenteral compositions also contain vitamins, trace elements, and water. Combinations of medium and long-chain fatty acids are optimal, and this needs to be met. Essential fatty acids, EFA deficiency, can be prevented by the addition of essential fatty acids in the correct combination. Linoleic acid and alpha-linolenic acid can be utilized. Amino acids, L-amino acids, and essential amino acids are used to supplement the feeds and based on the disease profile. Example, particular amino acids can be used in patients that have hepatic encephalopathy, and glutamine supplements can be augmented in critically ill patients. The electrolyte composition also needs to be adjusted based on the patient's evolving clinical condition. One would need to monitor vomiting, diarrhea losses, fistulae and drainages, stomocytes, drains. This will then allow for appropriate tailoring and augmentation based on the clinical need. Deficiency and toxicities of micronutrient requirements have been noted in parenteral nutrition. However, newer formulations have reduced this occurrence. The careful monitoring of patients receiving enteral and parenteral nutrition support needs to be monitored. This will identify the tolerance of diets and potential complications. Clinical parameters of weight, fluid status, septic status of the patient, gastric distension, and growth parameters need to be considered. This can be appropriately tailored based on short versus long-term needs. Patient clinical records provide a useful source of data for vomiting, diarrhea, fistula output, and input balance. And this then can inform adjustments to nutritional feeds. Also, patients need to be monitored for common complications that are associated with these different nutritional support methods. Monitoring of nutritional support by biochemical parameters. There are protocols available for laboratory monitoring of nutritional support, and this varies. It should contextualize the patient's needs and be performed in conjunction with a multidisciplinary nutrition support team. The frequency of monitoring can be adjusted based on patient stability and risk for refeeding syndrome. Ongoing biochemical biomarker assessment, however, in monitoring patients on parenteral nutrition has a limited role. An example of a laboratory monitoring guideline by NICE is provided in this slide. The URL is indicated, and it provides one example of a guideline. The protocol for laboratory monitoring from this guideline is snapshotted here. You won't be able to read the specific details, but importantly, you can appreciate the frequency of the different analytes can be contextualized for parenteral and enteral nutrition support, and the investigations then tailored based on the patient's status, health status. Complications of parenteral nutrition need to consider fluid and electrolyte imbalance. This is commonly encountered in this group of patients. Patients can present with hyperkalemia or hypokalemia, and these changes can evolve. Also, hyponatremia and hypernatremia can be encountered. Fluid charts and regular monitoring of patients, especially in their evolving profile of disease, need to be very carefully considered. Balancing water content is also important in the feeds. This will then avoid overhydration and avoid dehydration. So the water content and the electrolyte content can then be optimally supplemented and changed depending on how the patient is clinically evolving. Other complications of electrolytes include abnormalities with calcium, hypocalcemia, hypomagnesemia, and hypophosphatemia. Hypocalcemia can be secondary to hypomagnesemia, and the low magnesium levels can result from GIT losses and the drug regimen that the patient is receiving. Hypophosphatemia is commonly encountered in patients, and this is due to the rapid cellular uptake after starting the feed. We'll talk now to the refeeding syndrome, which builds on the last point. The refeeding syndrome consists of over-aggressive feeding of nutrition support, and it results in various metabolic abnormalities, which can result in systemic dysfunction. It occurs in oral, enteral, and parenteral nutrition support. There are various biochemical abnormalities that are evidenced: hyponatremia, hypophosphatemia, and hypomagnesemia and thiamine deficiency. These need to be monitored for and corrected accordingly. Importantly, the identification of patients at risk for developing refeeding syndrome can be informed before starting nutrition support. This will then enable a different approach, a more cautious approach to this group of patients and avoid the refeeding syndrome. A risk assessment can be performed on patients that can classify them into moderate or severe risk. The criteria used include BMI, abnormal pre-feeding electrolyte patterns, loss of subcutaneous fat, loss of muscle mass, and high-risk comorbidities. The risk of refeeding syndrome then in patients at moderate and high risk can then be attenuated. Thiamine supplementation can be commenced prior to starting nutritional support and be continued for approximately a week into nutrition support. So this then is augmenting the basal thiamine in the nutrition support. Also importantly, the commencement of nutrition support should be slower in this group of patients, and the target energy and macronutrient requirements can be slowly graded over the 24-hour period, over days. So in other words, there is a slow introduction of the nutrition support to avoid the refeeding syndrome. Other complications of parenteral nutrition include hyperglycemia, and this occurs frequently and in particular groups of patients. For example, old septic patients with pre-existing glucose intolerance or patients that are critically ill. IV insulin is quite important in controlling and normalizing the glycemic status. Hypoglycemia, on the other hand, can result if parenteral nutrition is abruptly halted and a rebound hypoglycemia results. Hypertriglyceridemia is observed in intercurrent diabetes mellitus, hepatic disease, and pancreatitis, and this needs to be appropriately identified and treated. Hepatobiliary disease is observed as another complication. Bilirubin and aminotransferase abnormalities are observed. This is not acutely, this is after weeks on parenteral nutrition, and it can occur more so in pediatrics. Steatosis, fibrosis, and cirrhosis can ensue. The pathophysiology implicates gut hormones that are reduced. There is cholestasis, accumulation of toxins, and hepatotoxicity. The use of polyunsaturated fatty acids using a soya source of fatty acids accumulates in parenteral nutrition and can accumulate in the liver, and this deposition results in steatosis. The role of lipid substrates in parenteral nutrition formulations thus needs to be considered, and different types of sources can cause decrease potential for hepatobiliary disease. Metabolic bone disease is another complication of parenteral nutrition. Bone pain, demineralization observed, and the causes are malnutrition, mineral deficiency, sometimes toxic contaminants within the parenteral feed, for example aluminium, medications, and illnesses that predispose to bone disease. In conclusion, nutrition screening and more formal approaches to nutrition assessment are important in identifying patients in need of nutrition support. This is especially so in the hospital inpatient group, where there is a very high prevalence of patients requiring this type of support. Nutrition support can be provided by oral, enteral, and parenteral routes, and the introduction of these feeds needs to be graded dependent on the patient's nutritional status and evolving clinical status. Also importantly, the monitoring and treatment of complications that result from nutrition support introduction needs to be managed by a multidisciplinary team, and this needs to then address acute complications and long-term complications related to both the introduction of the feeds and the feed itself, and this then can avoid serious adverse effects and curb morbidity.